Dementia, some people actually worry that some of the dementia is related to the slowness. They're not quick at responding, and therefore we think they're unable to respond. So it's taking our time with Parkinson's patients, and we do find there might be more capacity than we realize depending on the stage of the disease. So it's quite interesting. There's a lot of things going on. Drooling is another huge one that's happening. Didn't pass. Okay. So what are we doing with treatment? And that's kind of what I'm here to talk about. What we're trying to do is basically enhance dopamine. Our treatment at this time is symptomatic at most. We have very little neuroprotective studies done that have proved any benefits. We are seeing small neuroprotection effect from some agents at this time. They keep looking. There's new studies being done with proteins in the brain and everything else. So nothing there is right now is actually stopping or slowing the progression of this disease. So we're just trying to make us feel better and operate at the most efficient way possible so we can enjoy a good quality of life. That being said, we have to look at some things that might slow, and there's some new studies done with caffeine. Some people have probably heard it already. There is some data released from a recent study where they found that Lewy body diagnosis or Lewy bodies were diminished with people who drank 3 cups of coffee a day. And it was a retrospective analysis looking at everything. It was fairly well done. And there is some benefit to the effect of caffeine. And it seems to be separate from the dopamine pathway. So that's the initial data that I've seen, but caffeine, as I said, can also increase the levels of dopamine, and therefore it also may be related to that. From my reading, it seems to be any agent that improves dopamine in the brain may delay the onset to the dyskinesias because we're not having to initiate levodopa at higher doses as quickly. So there is a residual effect in the literature from using early dopamine therapies as well. It's not yet certain whether those are neuroprotective. So smoking may actually have a benefit. You're going to die of other things though, so let's not go there. I dislike smoking. Monoamine B inhibitors, and a gentleman's in here with the product called Dazzalect, have shown some benefits, but the data is very small and has not reached a good significant level yet. So we're looking at, again, early onset ways to improve dopamine levels in the brain to slow progression of the disease. So there is some work being done that way. When do we start treatment? It's so individual, like this disease. You know, if you want to golf every day, and you can't swing the club or you're not putting because you're shaking so much, we start treatment. If you want to continue work and you're having trouble with a good quality of life and you want to start treatment, you start treatment. Earlier treatment can lead to faster progression to end-stage results related to medication use. And I think that's one of the things that we worry about. So we always use the lowest dose of medication, and we delay the initiation of levodopa if possible. What we're looking at, and there's certain classes, is the levodopa, the monoamine inhibitors, because monoamines are dopamine and acetylcholine and serotonin. Those medications are those, those neurotransmitters in the brain that connect the, dendrites so that they can pass the message on and get the message to where it's supposed to go. The dopamine agonists, and a lot of people are on things like Mirapex and Requip. The COMT inhibitors, or COMT10, which is a catechol-methyltransferase. We have anticholinergics primary for tremor, and we have amantadine. And amantadine is not a drug that I enjoy using. We used to use it to treat patients with flu or to prevent flu in nursing homes. It's a very tough medication to dose because, again, pharmacokinetics and what the body's doing to the drug. But the other thing with it is I've seen a number of deaths related to too much amantadine use. So I'm not very happy with the drug at this time. So it's still an option. What are we looking at when we're looking at treatment is basically dopamine. And I think what this is showing that I've got patients that are, and I'm pushing the wrong button here, unable to move. You've got levodopa that's given, gets to the brain. You increase levels of, it's converted to dopamine in the brain so that the message gets through and allowing our patient to move. So basically, that's what it is levodopa is a chemical similar to dopamine. It's allowed to, dopamine itself does not enter the brain. I can give dopamine, you're going to get nausea, vomiting, and orthostatic hypotension and falls, but you're not going to get any effect. When I give levodopa, it's transmitted it gets through to the brain, breaks down into dopamine, and you get therapeutic response. So that's the way that one works. So what happens, though, is when levodopa it was first administered, or when levodopa was first administered, it was administered on its own. And you have to get much higher levels of levodopa into the system. And in the system, and we call the periphery in the body, it's broken down to dopamine, and you get nausea, vomiting, and postural changes. So people are falling, and they're sick, and they can't tolerate this medication, and it has a very short half-life. We talk about half-life of the drug, and it works. It takes 90 minutes for half the drug to leave the body. So if I'm taking it every hour, I'm getting a buildup of drug over time. If I'm taking it every 2 hours, it takes me, 5 times 90 to get to a balance. So you're talking, 450 minutes, work it out 7-8 hours before I get into a steady state. So within one day, you're actually getting into proper levels of medication there. So what they did with dopamine in order to get it to the brain without causing problems is we have two, we'll say, breakdown agents. These are COMT, which is catechol methyltransferase, and decarboxylase. And these prevent the breakdown of levodopa to dopamine in the system. It gets to the brain, it's now converted, and you get dopamine in the brain. So you reduce the incidence of side effects of nausea, vomiting, and orthostatic hypotension. So now you're getting medication that's working upstairs, not downstairs, and you're able to tolerate it quite well. Problem we get into is I need a certain level of this agents to block that. And what's used in Canada right now is the decarboxylase or carbidopa, but I need 75 to 100 milligrams, and we usually start with lower doses of Sinemet when we administer the drug. So patients initially getting Sinemet at lower dosage will have more side effects because we don't have enough medication to block the peripheral change of the levodopa to dopamine, and therefore when we start on low doses of the drug, you get more side effects of nausea, vomiting, and postural changes. So kind of a damned if you do, damned if you don't situation. You get started, you get used to it, you take it with food, and then when you get there, you can probably start fine-tuning your medication and your tolerance because you're getting extra of those medications in your system. So that's literally what's happening with levodopa here. Is we're giving the levodopa with carbidopa or with this carbidopa here. In Europe, they use more bensericide, which is Prolopa. You can also see where COMT inhibitors or COMT10 works at this point here because it blocks the breakdown of levodopa to dopamine, and in the brain it also blocks the breakdown so that you're getting longer effect of the medication when you get into the brain. So you're using less medication, tolerated better, and we're doing much better because of it. So we have Sinemet, we have Prolopa, mostly seen in Europe, but we are using it here. Prolopa is in capsules. You open it up and it's a granule. It's easier to administer in some people. I had a question earlier about Sinemet. It can be crushed. We can mix it into a liquid in order to make it water soluble. It's a quite large volumes that you have to take, but we do give it by G-tube or J-tube. We have a controlled release substance that is available. We don't use a lot of controlled release. I don't know if I had a show of hands. I'm sure there's enough people that are taking controlled release products here. They're more difficult to dose. They're more erratic in their dose response. So the only time I've actually recommended the CR product is at nighttime dosing, where some people require bedtime medication and I don't want to wake them up often, so I'll give an oral CR product at nighttime. But I've never recommended it, at least in the last 5 years. Stalevo is the newest one, and it combines the COMT inhibitor and entacapone, which is COMT10. Interesting to note is this medication must be given at the same time as levodopa in order to be effective, because it extends the life. So levodopa therapy is the most potent therapy we have for Parkinson's disease. It's also the one primarily causing dyskinesias and movement disorders and the on-off phenomena and the wearing-off phenomena. So these happen when you get to levodopa. You don't see them as much with the other agents, the dopamine agonists or the MAOs, because they're nowhere near as potent. When do you start treatment? That's, patients early on in the disease will actually better off started with agonist therapy or other therapies, because we're trying to delay the progression to the side effects of levodopa. Those people that are older onset, and the breaking point here is usually around 60, may be better off starting on Sinemet, but their dosage of Sinemet may be much smaller than we get to with the earlier onset patients. So we try to delay levodopa in these patients. So you're looking at primarily reduction in rigidity. It will affect the tremor, and as I said, because of restoring the balance with acetylcholine, which is the cholinergic effect where the tremor is responding to. The impairment in walking or writing, a number of areas will respond, except the postural hypotension. So you don't get response there where there's an improved alertness, swallowing, so you get a better quality of life. You also get improved sleep, memory, depression. You got all these things that are a benefit because the system is working up to par. When I look at antidepressants, it's interesting because the chemistry we use for antidepressant is norepinephrine, serotonin, and dopamine. So they're all the same thing. Even some of our skin disorders and salivation, drooling may respond slightly to the dopamine or levodopa therapy here. Significant improvements in quality of life, as they say here. Rapid onset. This drug is working in 15 to 30 minutes. I ask people where levodopa is absorbed. And I go back to my kinetics here is levodopa is actually absorbed when it passes through the stomach. So it's absorbed in the small intestine primarily. And a person who we've had a recent patient who's been put on a J tube, and you talk about G tube, it goes into the stomach in order to feed people, or you have a J tube which actually goes into the jejunum or the small intestine. This person receives crushed Sinemet or levodopa, carbidopa, administered about every 2 hours at this time. And you can almost see an immediate response with dyskinesia on administering that medication through a J tube. So it doesn't take 15 to 30 minutes when administered through a J tube. It takes 3 to 5 minutes. That's how quick this medication is in the system, and this person changes immediately. The problem we have is this disease is a slow disease, and gastroparesis or changes in stomach emptying will change the response to the medication, and it can change from day to day, from time of day to time of day. So the response to medication does vary. It's important that we take the medication on time, routinely, and it's hard. I know even patients out there are finding trouble staying with their medications and keeping track of the time that they have to take that medication. But your response can vary even if you're doing everything right. So don't blame yourself. We're all trying to do the best we can there. But most people, when they take their Sinemet, will find a response.